Hi, everyone. Thanks very much, Elder Cardinal, for opening us up in such a good way. Very grateful to be here on Treaty 8 Cree Territory. So Ray Markham, rural GP, rural family doc from the village of Valmont on Kletleten and Simp Territory. Originally from Zimbabwe, so born and grew up in Zimbabwe and have been practicing medicine in Valmont for over 20 years now. I met Jill. So Hinton is one of our referral centers. All Valmont babies are born in Hinton. And so I kind of met Jill in her time in Hinton. So yeah, really appreciative of the chance to listen here today and also a chance to share a little bit of what we're doing. John has given me the task of sharing 10 years of work in 15 minutes. So here goes. I'm going to set a little bit of context initially, and maybe a couple of commentaries. The best definition that I've heard of rural, there's so many definitions of rural. If you have Costco, you're not rural. If you have Tim Hortons, you're not remote. And so that kind of actually is a good rule of thumb that generally kind of aligns with a whole bunch of other things. But certainly one of the things we say at the Rural Coordination Center often is, if you've seen one rural community, you've seen one rural community. And so there's a lot of advantage in that because rural communities are very good at innovating and developing solutions for themselves. And so just releasing them into those spaces is going to be important. And a couple of the speakers have referred to generalism. It's one of the things that we're actually kind of looking at promoting and moving forward with. And one of the best definitions I'll point you to on generalism is the Royal College. So the Specialist College of Canada, their definition of generalism is an amazing definition. It really basically says scope of practice, the team that you have around you, and the need of the patient and the community in front of you. And that actually is where those all intersect is what generalism is. In British Columbia, we have the Joint Standing Committee on Rural Issues, which was kind of created out of conflict between rural physicians and the government. And basically, over 20 years ago now, both parties decided they didn't want to get into conflict again, so created this collaborative table. And so when we negotiate our physician master agreement, there's funding that's set aside for rural, called the Rural Subsidiary Agreement, and the Rural Coordination Center, which I lead with Leslie Carty, is basically funded out of that. Some of it. We're now also funded through a few other sources as well. We are kind of really a network, built as a network of rural physicians who are passionate about improving the health of rural patients and communities. We're not about improving the lot of rural physicians. We're about improving the health of rural patients and communities. We bring a rural physician perspective to that. And we really do work as a network. We kind of build into those foundational pieces that make networks grow. So networks are built of nodes, a relationship or communication between the nodes, and a common purpose. And so we kind of look, a lot of how we work is kind of around actually kind of that connection between those nodes. And you'll see a list of things here. And we have a lot of things that we do. The basic buckets of work that we do will be, we do projects, and I'll kind of show you a little list of those. This idea of being curious, inquiry, kind of advocating around policy, and then education and training is a big part of what we do. We have over 30 projects that we kind of run at the moment. You're going to hear from Sonia later on about the real-time virtual supports, which is one of those. I'm going to kind of just touch on a few pieces. These projects have all grown out of the people that are in our network. So the projects are really driven by kind of people who are motivated, who have a good idea that's aligned with the JSC's mandate is recruitment and retention of rural physicians. So I'm going to talk about one of the pieces of work that we started on and that was flagged as something of interest, is this Rural Learning Collaborative, which we started in 2019. We started kind of building on this partnership work, really trying to create spaces where multiple diverse partners can come together and start actually learning together and helping shape the system. Our kind of purpose, the coming together is really about improving the health of rural patients and communities. And we have developed this model, evolved this model called the Partnership Pentagram Plus. Now, a few of you who can count, I know this has 6 sides, not 5. The pentagram piece is really built out of a model that was developed for the WHO in the 80s around socially accountable health education. Is kind of adopted by all of the medical schools in Canada. And it really is looking at having the 5 partners simultaneously together around looking at how we build an education system that meets the needs of our community. We've had a lot of ideas and thoughts around what that might look like. So there was kind of interest at that stage, or certainly in that, if you read the original documents, the idea is it's a bit of a framework. It's not a, you have to do this, but it's a way of looking at who's at the table and who maybe isn't at the table, and what are the perspectives. So very much about not representing, but bringing perspective, and very much not about telling somebody else what to do, but being curious about what can I bring to the table, recognizing the power that each of us have to bring to the table. So policymakers, health administrators, providers, interprofessional providers, educators, academia, educators, researchers, and learners, and community, particularly those less well served by society, so by the health system. So certainly in our context, we have strong partnership with the First Nations Health Authority, First Nations Health Council, and First Nations. We've heard a lot about Indigenous kind of representation. The sixth partner, when we're coming at health system change, which we've adapted this model to look at doing, we've added in a group called linked sectors, which is industry and nonprofits. We all know in rural, they have a vested interest in a good healthcare system and health in rural communities, and they also have some responsibility in that paradigm. The QR code there, if you want to have a look at it, will take you to an interactive kind of place on our site, which we'll go through. Kind of this also can model out at scale. So we've kind of looked at applying this into a learning health system. And so basically, if you're looking at changing anything, we all have these learning cycles, and there's so many of them. I've kind of just put a couple in here. But fundamentally, you're going to look at something, and we're going to move this together. We're going to change this together. And then we're going to develop, generate some data around how are we doing now, what's changed. Data gets organized, becomes information. Information gets contextualized and becomes knowledge. And then at some stage you want to reflect on that, and we've heard some comments today around the fact of iterating as you go, so learning as you go and course correcting as you go. Chuck Friedman has this model of learning health systems, which I really like, and talks about platforms that accelerate those changes, and those platforms actually scale across other things, so they can help with this kind of learning cycle and help with other learning cycles. And we would say the Rural Health Partners, in the context of work that we're doing in British Columbia, really looks at deciding what we're going to do together. And then fundamentally, once we've developed some knowledge around what's changed or what do we need to do next. So what does it mean? So moving from knowledge to wise action. A lot of charts and references to what I think is a rural doc is a very simple thing. What we're trying to do is we've got a road in front of us, lots of rocks on that road. We need to decide which rock we want to move together and recognize that we all have a role to play in moving that rock. And then once we've decided on what that rock is, then we need to decide how we're going to move it. Because some of us have strengths in one area and some of us have strengths in another area. So we need to kind of balance our activities to make sure we're not tipping the rock on somebody else. That's fundamentally kind of really what this work is about. We have these partnership tables already established in British Columbia. We have one for rural health generally, a transport partnership table, which is co-chaired by PHSA and RCCBC. The virtual health and wellness, virtual health for rural and First Nations BC is co-chaired by First Nations Health Authority and RCCBC, and you'll hear a little bit of the work from RTVS that kind of drives the RTVS work. And then we have an education group as well. So I'm going to just kind of frame out some rural health concepts. I think a lot of these have already been touched on and described, but these have been kind of codified a little bit in a bit of a work that we've been doing over the last year in British Columbia around developing kind of a rural strategy and an action plan. And so these ideas of rural first input, talking about equity, I think has already been touched on, looking at an outcome-focused approach to the way that we do things. And then looking at our ways of changing our ways of thinking, and I'll come back to that in a little bit more detail later on. And then this idea of rural pragmatism and clinical courage and recognizing those things as being super important. Often we live in a system that is very risk-driven, and most of the time when we manage risk in the system, we manage risk to the organization, the institution, or the provider. We actually don't really manage risk to the patient. We don't think about risk to the patient. So I've had patients who've died traveling for an ultrasound. So should I order that ultrasound or should I not order it? It has a mortality rate when I do that. And so those are risk conversations that we don't often think about. So how do we enable the system to be able to consider those things? And then these ideas of partnership, we've already heard a lot of conversation around that it takes longer but is well worth it. System thinking is another thing. This opportunity, as opposed to running around solving problems, actually step back a little bit and start thinking ahead and planning a little bit for the medium and long term. And then the use of learning and data. So firstly, having rural people driving some of that, but then also kind of sense making of what that means. You've already been through this, so this is basically the equivalent of what we've already heard about kind of rural Alberta. Rural is important, and is actually not a net place of deficit. It's actually a net place of generation of resource and making Canada what it is, and certainly making British Columbia what it is, and Alberta what it is. And you've already had some presentations around this, is that the equity gap is not actually, there is an equity gap, and it's widening. So anything that we do in the health system should at very least not widen the equity gap. And this is part of the data-driven approach that we're trying to do. So we talk a lot about a disaggregated data approach. So when you're looking at something, and I'll talk a little bit to this around the edge concept, think about what the edge of that service might be, and then disaggregate that, look at the whole, and then look at the edge, and just make sure, ideally, that you're actually narrowing an equity gap in that. But if you're not narrowing, at least that you're not widening it. So this is some of the framing, and Kelly Gunn has been doing some work for us in British Columbia. She works for Northern Health and was doing some of this with for the Ministry of Health, but really looking at how you think about and implement system change. And I know this group is looking at rural policy, and that's kind of that top piece of it, but it's kind of the surface of things. So policies, practices, kind of resources are things at the surface. And while we're doing that, and those things are super important, I think we also do need to kind of look at things that underlie it, because if you don't get those things right, then the policy changes aren't going to make the differences that you're going to want them to make. And so I'm going to flip the approach and start with this idea of mental models. And just, there's a lot of conversation that can happen about mental models, but it's always worth raising it. And just actually, we all have mental models. We all have mental models about what rural is and what it brings. And so starting and encouraging those conversations for people to, at least in a non-judging way, surface and be aware of their mental models. Is rural a place of deficit or not? Should people who want better healthcare just move away from rural communities? Because those are mental models that are there, and people should at least be aware that they have that mental model when they're in a conversation. So this is just a kind of different way of reframing mental models and allowing people to move down ladders of inference if they are kind of aware of a mental model that they want to look at shifting. One of the practical things that we're looking at doing is kind of shifting into this concept of edge communities. And there's a danger in this of actually trying to define the edge and then seeing that as a fixed point, because I think the edge is different depending on what you're looking at. So for instance, I would say an edge concept for cardiac services is going to be quite different to an edge concept for primary care services, which is going to be quite different to an edge concept for emerge services. But just thinking about where is the edge in this, and then what are the impacts that we're expecting to make there, and actually having a look and seeing what they do. There's good evidence around investing in the edge. Lots of kind of benefits for investing in the edge. We often will build services in a hub and spoke model, and in a resource-constrained environment. There's this idea that you invest in the hub and it kind of flows out to the edges. And if you have abundant resources, that probably does happen to some degree. But most of the time, when there's a resource-constrained environment, there's kind of a sucking sound at the edges, and everything kind of pulls back into the hub model. And so there is a need for a hub and spoke model, but there's also a need to put some air in the tire around the spokes. So actually intentionally kind of invest in the edge as well. And I'm not going to speak too much to this. This is kind of really very similar to the previous talk around. These are kind of 7 areas that we're kind of looking at. Our government is, the Ministry of Health is currently looking at kind of these as pillars of work that we're looking at doing. And a lot of them overlap and align with, I'm happy to go into any of them in detail, but a lot of them overlap and align with the conversations that we've already had. And I will stop there. 14 minutes, 23 seconds.
Hey, think I'm good? Can you hear me? Oh, good. Thank you so much. And we're just going to take a couple of questions now, because then we're going to take a break, because I know people have been kind of intensely absorbing. But actually, I'll pass over just quickly to our panel for just some quick reflections, and then we'll take a break. We have another 2 presentations. Then we've got a lengthy time where we can hopefully get really interactive around some of the great, interesting things. And you can see there's a lot of commitment, but a lot of great things that are happening actually in other provinces. And I think it's because I could see actually Alberta's eyes kind of lighting up as they looked at some of the BC things, and vice versa. Hey, that's interesting. And I think it's interesting in Canada, we often don't collaborate across our borders as effectively as we should, and in our federal provincial system. So hopefully this can be the start of that journey. But a few quick comments, and then we'll take a break. So I'm going to go reverse to Jill in terms of the speakers, the last 2 speakers that we heard, of kind of key reflections that came to mind.
So this is a comment on Wanda's presentation. And I would like to point out that actually rural health is a distinct discipline. It's just not recognized by the people who have the power to recognize it. And that isn't just physicians, rural generalists, nurses and pharmacists and whatever, that until we actually identify it as a distinct discipline, we're forever going to be challenged by having urban people go, oh, well, they're just the same as family docs or nurse practitioners in the city, and they're not. So that would be my first comment.
Excellent comment. I agree 100%. And I guess I have something to sort of think about along those same lines. We talk a lot about grow your own. In healthcare, I think there's some unique challenges to grow your own. It is very, very difficult to go back into a community that you grew up in as a healthcare provider and now deliver services to your family. It's a different way of looking at things, and I think I liked what Ivy spoke about this morning. And investing in rural doesn't mean that those people necessarily go back to their home communities, but we'd like to see them go back to rural communities and to be that generalist and to understand what it's like to live and work in rural and remote communities, even if they're not going back to their own.
I was really struck by many of the similarities between what Ivy presented earlier and then what is in the Alberta plan and what Ray Markham presented in British Columbia. I mean, there's a lot of convergence around the important issues that are facing health and health care in rural communities, and a lot of commonality in the approaches that we need to take. So I'm really just very encouraged by this, by the convergence of what I've seen. It's not like we're seeing wildly divergent views of what needs to be done. We're seeing a lot of convergence and a lot of consistency, and I think our challenge is to actually just really, as was stated in Wanda's presentation, and good for you for moving right to the action plan instead of another strategy, but how to, to really just start activating some of these things now. That's always the Canadian challenge, to move to action, and but I'm really so pleased to see the amount of convergence in everything we've seen so far.
Is there any kind of last questions from anybody here for each other before we take a break? Okay, one thing, we are going to hopefully do a series of rural webinars in follow-up to this through the fall, because we're going to start to get a bit of a focus on things. So if anyone has ideas, and even online, they may identify ones of key factors that we're going to hold on to. But we're going to take now just a 15-minute break for people here and those online, and so we will come back at 25 after. Is that right? Yes, we'll come back at 25 after. Okay, thanks very much. And so take a break, those who are online, and we'll be taking a break here. Thank you.